Well, let me ask you guys something. Virtual reality to train students in an operating room to do a heart catheterization or a pacemaker implantation or heart surgery. Not so much to move their hands, but to handle adversity. In other words, when things go wrong, how do you internalize fear and anxiety and make yourself a better caregiver to your patients? So I think virtual reality may be an option. Also, what about using technology, and I'll toss this to the group, for patient education? Because if you're an empowered patient, you're gonna be a better patient.
Well, you know, how many times have we or caregivers handed that 45-year-old statin patient a tear sheet on what the side effects are, myalgia, all that kind of stuff, whatever category. And in my experience, it's always written for the 5th grader, right? It's the pharma standard is 5th grade education. Well, no 5th grader takes that med, number one. Number two, sometimes it's a PhD Stanford engineer who's taking it, and sometimes it's a mom in Alabama. We can customize this information using technology to probably 4 or 5 prototypes and make it so much more resonant. So just the application of technology in something as simple as communicating with our patients, I think, is intrinsically disruptive.
And you know, we're actually doing this in our group, and one of the things that excites me in the market today is Allscripts' acquisition of HealthGrid. They're a patient engagement solution we're using in our practice, and we're texting patients. You're turning 40 years old, happy birthday, guess what? Let me tell you a little bit about a mammogram and why you should come in and get one with Dr. Nair.
So let me just chime in on that, because you said something very interesting. You said happy birthday.
Happy birthday.
Boy, God forbid pharma engages in a dialogue. You know, social media is 80% social and 20% media, but pharma seems to focus on the ads, the pre-approved legal communication. So I think engaging in the dialogue fosters that disruptive communication process.
Plus, the patients want to hear from the doctor, right? And a lot of my docs are sending postcards. Happy birthday, make sure you come in. Is anyone getting those postcards? Anybody get those postcards? No, right? Where do I get it? My phone. I answer my texts, and right now, by the way, you can text your veterinarian, your dentist. Why not your doctor?
But remember, it should be the medium is the message for the individual patient, for the N of 1. I still get postcards. I like postcards. I still make cards because I love doing that, but absolutely, I'm online as well. So I think with the technology, you can tailor to the N of 1, whether it's a text message for millennials, a postcard for the mom in Alabama you talked about, or some sort of a secure email message for the Princeton educator.
So the medium is the message, but we can also customize the message.
Yeah.
And if I'm talking to an electrical engineer, I'm gonna do bar charts. I might even throw in a p-value. God, you know, that sacrosanct p-value.
But that's where the EMR companies come in, right? That's where these legacy health systems come in and have an opportunity to disrupt with smaller startups that are connecting the dots the way they can, right? Allscripts got the EMR data. They know how old you are. They know whether you like to go skydiving. They know if you've been in Hawaii, and maybe they will send you a postcard, Jane. But they can text you they can automate all of these things that John mentioned, which is, hey, remember to take that prescription.
But the issue is, Allscripts, not singling them out, and all EMR companies or for-profit entities. They're not going to do anything disruptive that doesn't put money in their executives' pockets.
But they have the data, and
They have it,
everyone.
but they're not necessarily going to use it in a way that we want them
Pharma's
to.
no different. The providers are no
Absolutely.
different. The EMR companies are no different.
We were promised universal electronic medical records, that interoperability, sharing of information, and each one of those EMRs have built themselves out separately in their own silos.
Correct, and that's where the consumer comes in, and that's where the consumer has to be the one that connects the dots, gets their information, and then can share it with Dr. Nair, Dr. Campbell, Dr. Nasta. I don't need the EMR company. I've got my own data.
But
here.
there has to be a business case for that, though. I mean, and you know, as much as I would want that as a patient, you know, I look at it as, you know, who has the incentive, the financial incentive to enable that interoperability? There isn't a clear one today. Right. And I think we need to create that. I don't know how we do it.
Legislated. It's the only way it's going to happen in the United States.
I actually think it's simple. I think it's up to the consumer, right? The only thing that can be legislated is the portal. You're supposed to go to the portal. We know no one's going to the portal. We are texting, right? We are actually texting people their information now. We're texting them lab results. We're texting them their history. And you are the only one that has the incentive to to share that as the consumer. I don't think that there can be a legislation that will fix this. It is about connecting the patient and the doc and making it easy to get your data.
But
So
let
who
me
are the
do one more
go
point on
ahead,
that, and
yeah,
then I'll let John go. But I would say that only comes about, the consumer demand for it will only come about when there's actual competition. And I think that's the key, because why would someone do that today, offer texting, offer videos, offer customized N-of-1 type of communications? Is because I want to attract more patients than my competitor. The problem today is that I don't think competition is that diverse. So I can, on certain docs, I can go from A to B, but for most, I just got A. I have no real choice. So there's no incentive for me to demand, hey, look, I'm only going to go to this one because they have texting.
Right.
This one does not. I think until that comes about, I don't think we're going to see as much consumer demand.
Well, I do think she's right. Consumers have to drive this. Physicians have to drive this as advocates. But right now in the United States, Epic is the big player, and Epic is, in my opinion, one of the worst interfaces out there. And it's not done for the patient. It's not done for the doctor. You know what it's done for? It's designed to capture the maximum amount of billing possible for the hospital system.
And that's why as payment changes market to market, we don't have national wide value-based payment yet, bundled payment, pay for performance. But in certain markets, we do. If you look in San Francisco, LA, parts of North Carolina, Miami. I'm in Philadelphia, 6 medical schools. You better believe we're going to be one of the last places where that happens. But we have seen where payment is aligned, physicians cottoning on to these new technologies, and patients have begun, because I track this stuff, begun to change doctors based on access to a portal that makes sense, email, and that's why we've seen the concierge movement amongst people who can afford it. But it's the payment stupid.
Let me throw a question out that's related to this. You just hit the nail on the head. Hospital systems are motivated by payments and customers and that sort of stuff. Doctors care about patients, but still you have economic pressures. What about patient-reported outcomes? That's going to be a huge source of pressure for change and probably disruption as well. What do you guys think?
Well, I wanted to just follow up on the whole thought here. So I wrote down, I think the 2 biggest disruptors are the geeks, the data scientists, because I really believe that those insights will be quite profound. But on the other side of that spectrum, I think it's going to be the moms and dads. I believe that the collective intelligence of patients and patient groups are smarter than the physician. I get pushed back on that, but talk to a mom or a dad who's got a kid with cancer. They know the labs, they know the medical history, they know the trials better than some of the oncologists. So I think that's going to be a very powerful empowerment. So the patient voice is going to be an extraordinary, look, it's Yelp. You know, it's going to go down that road where
the government says we're not going to get paid the same unless we have certain metrics met with patient-reported outcomes, and I'm all for that.
Listen, it's just like banking, right? We all now have access to a mobile bank, to an online bank, to an ATM. I don't even know the last time I went inside to a bank, right? Now, am I the best person to manage my money? I'm actually not really that good with financials, right? But I hire someone who is. So I think to John's point, patients need access to the data, and they may better manage it than many of the different stakeholders that are in the mix for them. They have every reason to. You know, a mom with a sick kid, they are the best patients you can possibly have because they are absolutely on top of it, but they need the data and the tools to be true advocates as patients.